Hello everyone, this is Jisoo Park and I'm a PhD candidate at Carnegie Mellon University. And I'm very excited to share a project that I'm working on to understand how employing contractors affects organizational learning in the context of US hospitals. So in this paper, I ask how hiring contractors affects organizational learning, and I especially focus on when full-time employees can effectively integrate knowledge held by contractors and vice versa. So contractors can potentially facilitate organizational learning because they can bring diverse and unique knowledge from their other affiliated organizations to the recipient organizations. However, the knowledge transferred by these contractors might not be as effective unless integrated with the knowledge specific to the hiring firm, such as the knowledge of the hiring firm's coworker skills. Also, mixing full-time employees and contractors can potentially hurt group relations, and this may reduce full-time employees' likelihood of utilizing contractors' knowledge and vice versa. So, drawing from the theories of majority and minority relations, I propose that the effect of hiring contractors on organizational learning will depend on the proportion of contractors in an organization. And specifically, this theory suggests two opposing effects that can be created by increasing the proportion of contractors in an organization. The first set of theories suggests that increasing the proportion of contractors in an organization can improve knowledge integration, and this is because the natural increase in contact between the full-time employees and contractors can help full-time employees reduce their stereotypes toward contractors. And because this can improve the quality of interaction between the two types of employees, the likelihood of utilizing each other's knowledge will also be improved. And on the other hand, other set of theories suggest that increasing the proportion of contractors can hurt knowledge integration. And this is because full-time employees can potentially feel threatened toward contractors as there are more contractors in the organization. And this will hurt the quality of interaction between the two employees, which will reduce the effectiveness of knowledge integration. So considering the net additive effect of both processes, I predict that organizations with a moderate proportion of contractors will be more effective and at organizational learning than other types of organizations. And this is because the knowledge integration will be most effective because the quality of interaction between the two employees are high, but contractors are not as many for full-time employees to feel threatened yet. So the negative impact of increasing the proportion of contractors will be minimized, while the positive effect of increasing the contractors will be maximized at this point. And specifically, I'm looking at organizational learning in terms of adopting industry new best practice. So here comes my hypothesis, which says that organizations with a moderate proportion of contractors would adopt industry new best practices more quickly than organizations with a low or high proportion of contractors. And I test this hypothesis in the context when the American Heart Association and the American College of Cardiology released a guideline in 2006 that recommended physicians to abandon stents in favor of medical therapy to treat low severity, stable coronary artery disease patients. And organizations' timely adoption of the best practice represents effective organizational learning in this context, and this is the important organizational learning outcome because following the industry new best practices can improve patient care quality and reduce healthcare costs. And also, this is an ideal context to examine my research question because physicians either work as traditional full-time employees or contractors who work across multiple hospitals. And I use three data sets to test my research question. And my main data set is New York State Community Hospitals quarterly inpatient discharge data between 2004 and 2007. And this data set includes patient level information, such as what kind of treatment the patients received, which diagnosis patients got, and which hospitals that they were admitted to, and other patient level characteristics such as patient's severity or patient's economic status that could have affected a patient's likelihood of receiving stents. Also, I use New York State Department of Health reports of PCI outcome reports to identify hospitals that are licensed to perform stents. And finally, I use American Hospital Association's annual surveys to control for several hospital level variables that could have affected a physician's likelihood of using stents for certain types of patients. So my final sample includes about 85,000 patients treated in 40 New York State hospitals between 2004 and 2007. And my dependent variable is whether stent was used to treat the patient or not. And because the best practice guideline recommended to stop using stents, not using stents and decreasing the likelihood of using stents means effective organizational learning. And there are two types of independent variables. My first set of independent variable is piecewise linear time splines, period 1 and period 2. And these time splines measure the quarterly rate change in the likelihood of using stents. And more specifically, period 1 captures the quarterly stenting rate change before the guideline release, and period 2 measures the quarterly stenting rate change after the guideline release. So this is an effective measure to look at how organizational learning changes over time. And to test the difference in this organizational learning over time, I create two dummy variables to capture the hospital's proportion of contractors. The first dummy variable is low, which indicates the hospitals with a low proportion of contractors. And my second dummy variable is high, which captures hospitals with a high proportion of contractors. And hospital with a moderate proportion of contractors will serve as a baseline category. So to test my hypothesis, I'll create interaction terms between the time splines and the low dummy variable and the time splines and the high dummy variable. And specifically, the interaction term between the period 2 and low dummy variable will indicate how quickly or slowly the hospital with the low proportion of contractors abandons stents after the guideline release compared to the moderate proportion of contractors hospitals. And the same similar interpretation applies to the period 2 and high interaction terms. So I'll use linear probability model to test my hypothesis, and I include physician and hospital fixed effects and cluster standard errors by hospital and quarter. And I also control for various patient, physician, hospital, and region level control variables that can affect the likelihood of using stents in addition to my independent variables of interest. And here are my results, and it'll be easier if you look at the graphs first. So the y-axis represents the predicted likelihood of using stents, and the x-axis represents the time, and the vertical line in between represents when the guideline was released. So the lines before this vertical line represents the predicted likelihood of using stents for each hospital before the guideline release. And the lines after the vertical line represents the predicted likelihood of using stents after the guideline release for these three types of hospitals. And the solid line here is the hospital with the moderate proportion of contractors. And as you can see, after the guideline release, the vertical line, you can see that these hospitals are decreasing the likelihood of using stents as recommended by the industry best practice guideline. So hospitals with the moderate proportion of contractors are indeed learning effectively. On the other hand, hospitals with a low or high proportion of contractors are continuing to use stents even after the guideline release, and this represents that these hospitals are not learning effectively, and the differences between these hospitals are statistically significant as I hypothesized. So these results support my hypothesis. And this study has several important implications for diverse literature. First, this study contributes to the organizational learning via personal mobility literature by shedding light on the conditions that facilitate the integration of knowledge transferred by moving individuals, contractors in this case. And also, this research contributes to the micro foundations of organizational learning literature by examining how the interaction between different types of individuals affect organizational learning. And lastly, this study has implications for organization design and strategic human capital literature. And several organizations hire contractors to achieve flexibility, but this research shows that employing contractors may affect important other organization outcomes, such as organization learning, that firms have not envisioned when they were deciding to hire contractors. Overall, this is a very exciting project, and thank you for listening.